Hi guys, it's me again, Kamil Rückert from the Psychosomatic student group Riga, and today we'll be talking about psychosomatics and dermatology. This will be a rather short lecture, just trying to give an overview again about what psychosomatics actually is. And the art of this lecture is Shirin Nishat, a Persian artist who lives abroad, to my knowledge, and she often incorporates writings on photographies, on pictures, and especially marks the faces with Persian writings. And hopefully throughout the lecture you'll understand why I chose this picture. So we will mainly talk about what is psychosomatics, how can we apply psychosomatics to dermatology, and give some examples of illness. So, what is psychosomatics? And for those of you who have already watched our student lectures, you might know this, but as repetition lies at the core of learning, let's repeat it. Psychosomatics is divided up into psyche and soma, so the soul, the mind, and the body on the other hand. And the connection of those two words really should show that it's a reciprocal relationship of psychosocial and physical processes which are intertwined, meaning that health is not really based on only biology or only psychology or mental processes, but in reality it's a mix of both. And as Ture von Uexküll and Michael Balint would say, it is a very person-centered medicine that focuses on the personal relationships, on the conflicts the patient has in relationship to the disease, to the illnesses that develop. And it can generally be divided up into three main areas: a general approach, a scientific approach, and a psychotherapeutical approach. The general approach could be described as a basic attitude, and Ture von Uexküll once described it as medicine curious doctors. So in this sense, the doctor should not just watch, make a diagnosis within a couple of minutes and prescribe some drugs, but also listen to the relationships. It's also a specific area of research that is very interested in the quality of life, in the emotional coping of certain illnesses. Think about oncological illnesses, for example. How can those be incorporated? At the same time, research is also regarded in the psychotherapeutical way. Is it effective? Which therapy is the most effective? Differences in CBT or psychodynamic approaches can be investigated. And last but not least, it's an area of medical service, which is a psychotherapeutical approach in which talking, investigating the conflicts, and transference, countertransference is at the core of it. So, psychosomatics is not psychiatry. And while this might be not a big deal for most German or European medical students, because Europe actually has the specialty of psychosomatic medicine, this might be quite interesting for the Anglo-American or the American medical students out there, because essentially it is different, but it has some points of contact. Psychosomatic medicine focuses mainly on somatic or physical complaints with a psychogenic genesis and mental distress due to primary somatic complaints with a focus on psychotherapy. So this is really somatoform disorders, conversion disorders, everything that is about mental distress forming symptoms and about somatic illnesses that are hard to cope with. And psychiatry, on the other hand, focuses on organic mental disorders. So those are schizophrenia, very severe depression, that are really due to an organic change. Alzheimer, for example, dementia, those are parts that psychiatry deals with. And the main focus here is not, and I would say unfortunately, not on psychotherapy, but on the pharmacotherapy. At least in America, in the South American countries, this might change, or in some European countries. And at the same time, both specialities really have 3 points of contact. One are the depressive disorders, one are anxiety disorders, and personality disorders. These are really traditionally in both hands, and it's really I think, scholarly discussion of which should belong to whom and so on. So now that we took a look at what psychosomatics means, how can we apply this to dermatology? And in general, I thought of the 3 ways: the general approach, a scientific approach, and a psychotherapeutical approach. While I won't really go too much into depth on the scientific approach, let us maybe jump in to the general approach and ask a question. Can you think of any phrase connected to the skin in really our general or traditional language? Do you have something maybe in your native language? Maybe it's Latvian, German, Swedish, or English. And you can pause the video to maybe think about something before we continue. So skin in the traditional language is really regarded as a metaphor for our feelings. In German, at least, it is regarded as the mirror of the soul. And this is already maybe the explanation why I picked Shirin Neshat's art, because in some way we traditionally believe that our skin shows our emotions. You might feel well in your skin, you might not feel well in your skin. In German, we have the expression eine harte Schale, which means to have a hard shell, or kind of the skin is regarded as the armor of one. And well, this is obviously a very biologically based point. It is also true psychological wise. The skin can give you goosebumps if you're excited, if you're in disgust sometimes. It makes us flush. And you might hear someone say, "Oh, you don't look well today," or "You look really good today." So the general population in the traditional language regards the skin to be a reflection of our emotions and our inner world. And I think this is already really interesting for doctors, because in this way, if we remember this, it might help us to focus more on the words patients use. What are the specific things they point out while we take the anamnesis? And it's also always good to keep in mind that the psychodynamic or psychoanalytical theories regard the symptom to an extent as the language of the unconscious. Symptoms, in their point of view, are formed when there's a conflict or an emotion which is unbearable to us for our ego, that we basically suppress it, that it's in our unconscious, and it tries to find a way to make itself recognizable. So these metaphors already help not only for us to remember it, but maybe also to talk to difficult patients about the connection, to give an example of how one might perceive the skin. And it gives us a chance to remember the WHO definition of health. That really illness or health is not the absence of a disease, but really the interaction of biology, of sociology, and psychology. So let's look at the treatment in dermatology. And traditionally, the treatment is mainly based on biology, so on the pharmacology, we give certain drugs that could be, for example, immunosuppressants or antiviral drugs, and so on and so on. And at the same time, we have a very device-based dermatology. We have these UV light devices, we have cryotherapy, and. But research suggests, and this is just one of many, that 1/3 of all dermatological patients suffer from a psychological disease, and that distress is a known factor in its pathology. So in this case, it's rather strange to realize that we have 1/3, or that we have a large number of patients suffering from psychological distress. But we only, as doctors, offer biological or device-based treatment. And this is especially interesting for some classic illnesses of dermatology that really are known to have the psychosomatic component. We have atopic dermatitis that in the German-speaking countries is often referred to as neurodermitis, because early scientists thought there must be a connection between the neurons and the skin that basically starts this illness because it's so connected to stressful events. We have psoriasis, we have malignant melanomas, we have urticaria, acne vulgaris, and artificial disorders. And the tears often, it might be that the illness is also its etiology is based in distress, but also the disease itself, in the example of malignant melanomas, can severely impact our psyche and our mood. And maybe because we doctors or us medical students really like to see graphs and to look into this biology, I thought we could look at the example of atopic dermatitis. Most of you will probably know that it is a multifactorial disease with a very strong genetic component, which can be regarded as a gatekeeper, because if you do not have the genetic components, it will not be triggered. But 1/3 of the patients who have this genes have a distress trigger, meaning that each time they experience emotional distress, the disease is triggered. And this is really a key idea of psychoimmunology. It teaches us the link between emotions and immunomodulators. If you're more interested in this question, maybe take a look at our lecture at Psychosomatics Reel. It was the first one we uploaded, and the graph we show here is from this lecture. So in general, what happens when our brain is, or when we are in distress? Our adrenal gland is activated and cortisol, the stress hormone, is released, which really has a negative impact on our immunological cells. At the same time, we have the autonomic nervous system, which is activated, and through nervus vagus itself modulates immune cells, and vice versa. Immune cells have a negative effect on the brain function, and this could kind of lead already to a vicious cycle. And in the case of atopic dermatitis, it is shown that distress activates the rise of interleukins 4, 5, and 13 to the interferon gamma T helper cells, and it increases the eosinophil count. So this is something that really you can look up to or write in the comments, and I can send you the literature on this. But I think most medical students are interested in that. So now that we thought of some diseases, or we've seen some diseases, we've seen an example how it develops, the question is, because of its really prominent character in dermatology, how do we divide it? And Gila et al. Really thinks it's necessary to categorize this because we have three main classes. We have those dermatological symptoms that are due to an underlying psychological or psychiatric disorder. We have those dermatoses with multifactorial genesis, for example, atopic dermatitis that we just talked about, and psoriasis. And at the same time, we have or the third class are psychological disorders as a comorbid or psychological complication of a dermatological illness. And those could be described as somatopsychic disorders. Think of a malignant melanoma or cancers. Those are comorbid psychological disorders due to a dermatological illness. And you can see on the right really the idea of when treatment should be initiated or what kind of treatment should be initiated. And this again is already a question where a lot of people go into different directions. So the indication for psychotherapeutical treatment should be based on the severity of the interactional problems, severe difficulties in coping, the presence of a conflict that kind of keeps on initiating the disease, personality disorders, and neurotic conflicts. Some other authors say that if the symptom or if the dermatological symptoms are always present in the light of emotional distress, one should really tell the patient to look for psychotherapeutical treatment. Also, severe phobias and avoidance really strategies due to the dermatological disease should be treated or should be encountered with psychotherapeutical treatment. And if we have excessive manipulation of the skin, not of the sky, due to itching. So what can we do? I always said it's psychotherapeutical treatment, but in fact there are many different things that patients, or many different strategies that patients can choose. But let me just say that most studies found that it is more effective to go into psychotherapeutical interventions as well as somatic treatments than purely looking for somatic therapies, so meaning drug-based therapies or device-based therapies. So we have already different types of psychotherapy. We have CBT and psychodynamic treatment. We have psychoanalytic treatment and so on. But there are also self-help groups in which people who share the same disorder or the same illness can find some help, can find some common shared problems. We have psychoeducation that is usually given in hospitals, but dermatologists can also offer advice or introduce the patient to the idea of psychosomatics and how both diseases are intertwined. We have ambulatory and stationary psychotherapy, meaning one can be in a hospital, at least in Germany, for a longer period, or go to an ambulatory psychotherapy, meaning just going to a hospital once a week for psychotherapy and then leaving. Then we have psychosomatic basic care from GPs or dermatologists who maybe take some time out of their usual routine and try to have an extended talk. And then again, there are stress-reducing techniques. Nowadays, we talk a lot about mindfulness, meditations in general, but there's also progressive muscle relaxation techniques or autogenic training. And that's it with my lecture. I hope you enjoyed it. I hope you keep in mind that it is a student lecture. And I hope that maybe you watched it as a medical student and found it interesting and gain more interest in the idea of how to talk to a patient and what underlying conflicts could be present or what kind of stress could be present. maybe you're a patient who watched this to educate him or herself. And if you enjoyed it, visit our website or follow us on YouTube. And I hope you had a nice time. Bye bye.